Hi, this is Julie Lubinsky. I am the web manager for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to our live chat with Nurse Linda. Nurse Linda has been a leader and a provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for about 20 years. And she is also the moderator in our Ask a Nurse online discussion in our online paralysis community, where she focuses on contributing functional advice, providing the how-to on integrating various healthcare improvements into daily life, and answering your questions. And once a month, we are lucky enough to have her live talking to you all, answering your questions. So now I will turn it over to Linda. Hi, Linda.
Good afternoon. Thank you, Julie. And hello, everyone. Welcome to the blog today. I've been writing this month. I've kind of been building up. There's been a method to my madness this month in that I started talking about surgery in general, and then the different nerves, cranial nerves and the peripheral nerves, and then got into some very basic information about transferring of nerves, because a lot of people are really interested in this topic. And you certainly will read a lot about it if you do any kind of Google searches about spinal cord injury. There's a lot of information that's just recently being released, and scientists all over the world are working in this different parts. So I was lucky enough to work in an area where a lot of these transfers were being done. So it was a very exciting opportunity for myself, and certainly a good experience for most people who had some of these nerve transfers. But just some general thoughts to get started with the topic is, just talking about surgery in general. Surgery is something that is necessary. Sometimes people have things that go wrong in their bodies, and they need to have some surgery to correct that. And so it's a very good thing to have that opportunity to take care of problems. People who have spinal cord injury from trauma generally have had some surgery at some point in their life to stabilize their spine. Then once that surgery is done, they're able to get up and move about and start with the rehabilitation process. So surgery is a very good thing, but it does come with risk for all people. So whenever you talk about any kind of medication, treatment, therapy, surgery, there's always going to be some risk, and there's always going to be some benefits. And so, of course, you want the benefits to greatly outweigh the risk. And the benefit is always a successful surgery, which results in some kind of increase in function, or if you're having surgery for a medical problem, to eliminate whatever that medical problem is. So surgery is a very beneficial activity. I do think that people who are doing elective surgery, so surgery that they've decided on their own, I'd like to have this particular procedure, it's not going to, be an issue of life or death, as removing a cancerous tumor can be an issue of life or death. But elective surgery, thinking about different surgeries, and there's a huge variety of surgeries that can be done to help improve the functional ability of your life. And one of these type of surgeries are nerve transfers. So, but there are risks for individuals who have spinal cord injury, and just from looking at things like breathing, because when you have surgery, general surgery, you're put on a ventilator to breathe for you while you're anesthetized. And so it's more difficult for people who have spinal cord injury at any level to get off the ventilator and start breathing again on their own. And the reason for this is, even if you have a higher level, you have certainly more problems with breathing. But even if you have a lower level injury, you can still have some problems with breathing, because we all know that we use our lungs and they expand and contract when we breathe. But we also use these very, very fine little muscles that are in between the ribs. They're called the intercostal muscles. And those are controlled a little bit lower on the spinal cord. And also the abdominal muscles play a part in breathing. And those are controlled even lower those nerves come out even lower on the spinal cord. So as you can see, there's some difficulty in trying to breathe again if you have limited muscle function anywhere in your body for with the breathing nerves. The other thing is that you're also on a surgical table, which has some pressure dispersion cushions on the table, but you might be on the operating table for quite a lengthy period of time. So sometimes the surgical staff will get extra cushioning or get a higher level of cushioning for you to lay on because they're not able to turn you during surgery, because that will mess up the operative area. Of course, for anyone, there's the chance of bleeding or infection. People with spinal cord injury are more prone to infection because their immune systems are being assaulted in different daily treatments. So there's just all kinds of higher risk of complication possibilities for people who have spinal cord injury. But if you think that your benefit is more than your risk, and certainly the operative staff, the anesthesiologist, the surgeon, they certainly do practice measures to reduce your risk as much as possible. So if you think your benefits would outweigh your risk, then you should go ahead and consider surgical intervention to improve function for you. So that is one point that I want to make is sometimes people think, and people tell me these things, and this is why I'm under this impression. Not everyone, but some people will tell me, well, it's just surgery. There's no risk to that. They've done surgery for hundreds of years. Well, that's true, but there's still risk, and there's still more risk if you have a spinal cord injury. The other thing is that sometimes people are kind of glib about surgery, and they'll say, and I even hear some surgeons say this to patients, say that, you're going to have surgery, we're going to put you to sleep, and it's just like spending a day at the spa. You'll just have a really good nap. Well, in actuality, anesthesia is not like taking a nap. Your body is paralyzed basically through the anesthesia. And so there are some effects that you have. The drug stays in your body. Some people don't wake up easily from anesthesia. They have kind of like a little hangover, so to speak, from it. They might be stiff and sore. Some people say, well, I've been asleep all day in surgery, so I won't sleep all night tonight. And in fact, they do. It doesn't seem to mess up your circadian rhythms that much. So if you're used to sleeping in the nighttime, you'll still sleep in the nighttime. If you're a person that has difficulty with sleep, you'll still have that problem after surgery. So it's not like you get a good sleep while you're doing that. It's a little bit different effect on the way that your brain is thinking. When you're sleeping, you get that rapid eye movement sleep, which is your deep sleep, and you don't have that in surgery. You're just knocked out is basically what happens to you. Thinking about all of those things, they do try to minimize any kind of side effects or effects of the surgery. And yes, even though you have a spinal cord injury and you don't feel below the level of your injury, your body still reacts. So I don't think we have any more surgeons out there that don't anesthetize people before surgeries. Sometimes in the past, this is in the distant past, but in my lifetime, I've seen patients with spinal cord injury go to have surgery. The surgery site is in an area where they don't have sensation, and so they just do the surgery because the patient doesn't feel it anyway. It's like, oh, my goodness, but their body still reacts to it. And so their nerves are still working down below the level of the injury. They're just not getting a message to the brain. So the message may not be received by the brain, but the body's going wild when surgery is going on. So you definitely need anesthesia. Women who have children oftentimes don't get any kind of medication during childbirth because they don't feel in that area, and so that is something you want to be sure because your body's still reacting, so you still want to have medication. Even if you're having something like we'll say like a wart removed off your foot. You don't feel in your foot, but if anybody's ever had a wart removed and they spray that really cold stuff on your wart so it freezes and falls off, you still might need the same kind of treatment that a person who has feeling. So you don't want to set your body into a tizzy. So that being said, there are basically two kinds of nerves in the body. There's the nerves from the central nervous system, and there's the nerves that arise from the peripheral nervous system. So the central nervous system nerves are in the brain and the spinal cord. And I did a little article about that just so you would know what the difference of those are. They can't operate on those nerves right now. You can have brain surgery, but it's hard to get to those nerves. So there's not a lot of surgical interventions. They can release pressure if those nerves get compressed. Like if you've had a stroke and there's blood in your brain, they can release the pressure on the nerves. And with intervention, generally speaking, nerves in the central nervous system tend to kind of heal on their own. Those nerves are contained like underneath the base of the brain or the nerves in the spinal cord. They're very well protected with the skull and the vertebrae, and they're really deep inside those structures. And the reason for that is that they shouldn't be messed with. Anything that's that buried within the body probably don't need to be messed with. But to get to those nerves, you would have to destroy other nervous tissue to actually get there. So they're very difficult to operate on. And, to operate, if you would go into the area where your spinal cord is, where your spinal cord injury is, then you have to go through healthy nerve tissue to get to that hole where your spinal cord injury is in the center of your spinal cord. So you don't want to cause more damage. So generally those are not operated on in the most general sense. Now the peripheral nerves are all out in the rest of the body. So any nerve that's outside the brain and the spinal cord are peripheral nerves, and those are fair game for surgery. So people have surgery on these nerves where the nerves are transferred from one target they call where the nerve ends. All the nerves arise out of the spinal cord. They're in pairs, and they go on each side of the spinal cord. So you have a nerve that goes in your right arm, and you have a nerve that goes in your left arm. They're paired together, but they come out separately on each side of the spinal cord. So you can have a peripheral nerve injury on one side of your body and not have it on the other side. Whereas the central nerves, like in the spinal cord, where you have a spinal cord injury, usually the result is pretty even on either side of the body. Sometimes people will have what's called a zone of partial preservation, and maybe the injury will be one or two segments lower on one side of the body than the other from their spinal cord injury. But in the peripheral nerves, they're separate nerves. They're paired together, but they're separate. So you can have a nerve injury on one side of the body and not a peripheral nerve injury on the other side of the body. These nerves can become entrapped, or they can be in a place in the body where the surrounding tissue have gotten too tight. So if you think about carpal tunnel. I think everybody knows about carpal tunnel injury, and that's when the nerve from the arm to the hand gets entrapped. It's too tight in the little tunnel right at your wrist where the nerve goes from your arm and then goes down into your hand. And the median and ulnar nerves in the arm go right through this little tunnel, and sometimes it gets a little too tight and it pinches that nerve. So you get some numbness and tingling in your fingers. Sometimes people get like shooting pain. Sometimes they feel like their hand is asleep and it doesn't wake up. Sometimes you can rest your elbow on the table, and your ulnar nerve at the elbow, there's a little tunnel there, it gets temporarily compressed, or maybe you're sleeping at night, your hand goes to sleep, but it wakes up again. when you start moving it around because you release that pressure. So in the carpal tunnel surgery, what they do is they make a little incision in the wrist, and they just release. They don't touch the nerve, but they release around the nerve, and that allows those messages to flow through, because it's just like anything else. If it gets too tight in there, you can't, the nerve won't conduct its energy. So Thomas has his hand up, so let's go ahead and ask Thomas. Hello, Thomas. What is your question?
Do we have any audio calls right now?
Currently, there are no questions in the queue. Once again, that is *1 if you'd like to ask a question over the phones.
Okay, I misread the page then. So I'll just continue on. So releasing the pressure is one thing that's done. And then there are tunnels all over your body where the nerves can get trapped in the wrist. As I mentioned, in the elbow, they call that cubital tunnel. And then up in the neck where the brachial plexus and the thoracic outlet are, those can get entrapped up in the shoulders. And then there's also some places in the legs where you can have at the knee and then down by the ankle where you can have some entrapments. So those are just released. Now it's interesting to note that people who have more entrapments are people who are heavier, or sometimes women who are pregnant will have problems with nerve entrapments, especially carpal tunnel while they're pregnant, because they have so much more fluid in their body while they're pregnant. And so they sometimes get carpal tunnel, but they don't have surgery for it, because after the baby's born, their fluid goes back to its normal levels and the problem just resolves, which is very nice. So entrapment is one thing, and the other thing is when a nerve becomes damaged. And what will happen at that time is the peripheral nerve is actually damaged in some way. You can go to a specialist and see about having that nerve split or transferred from another nerve to give you the function that you need back in your body part. So usually, most often in spinal cord injury, nerve transfer surgeries of peripheral nerves are done in the upper extremities, because there's so much more nervous tissue up there from the brachial plexus, and people really want to have hand function, and rightly so. So you see a lot more requests for nerve transfer surgeries with people who have higher level injuries. Now, there are requests for nerve transfer surgeries with people who have lower level injuries, so in paraplegia, and those can be done, but are not done as frequently. And the reason for that are kind of a couple-fold. The nerves can be transferred, and you can have different nerves moved around so that you can accommodate for issues in your legs to help give you hip flexion and extension, and to help you move your knees, and to give you a little more mobility. So why aren't those just done all the time, or why aren't they done more? And the reason for that is because standing is a much harder function to obtain than moving your hand. Your hand is small, it's light, it's at the end of your arm, so it's kind of operating out there away from your body. If you're trying to do standing and you move nerves around, it can be done. It is successful, and you can achieve standing function. Some people can achieve some walking function, but the problem is with the sensation and noticing of balance and holding yourself up when you don't know where your legs are in space. And it makes it very, very difficult. So people who have had this surgery will usually rely on splints on their legs, as well as using a walker. And so what they do is they have to hold their body basically up and maintain their balance with their arms, which is very fatiguing, because your arms aren't really designed for holding and maintaining your body weight. So it can become really difficult while you're trying to move one leg forward and propel yourself walking along. And it becomes so exhausting is that what happens is that people who generally have the surgery with the transfers in that way, they may they may try walking for a while, but after a while it becomes just so fatiguing that they just kind of give up on it. So in a way, it's a successful surgery, but the outcomes aren't really that functional. Another surgery where they transfer a lot of nerves, where people are extremely interested, is for bowel and bladder control. And these surgeries are becoming more and more refined. So the cauda equina, as people with spinal cord injury know, is the very tail end of the spinal cord, which comes out at the very last segment, and it's a series of nerves. They call it the cauda equina, meaning horse's tail. So your spinal cord comes out, a bunch of nerves come out right at the end, and then mostly are those nerves right at the bottom of the spinal cord are controlling bowel, bladder, and sexual function. And so what is happening is that they can move some of those nerves around to help you achieve better bowel, bladder, or sexual function. But it's very difficult surgery. There's just a tremendous amount of nerves that are operating to perform those functions. So it's a very, very serious kind of operation. It's a very delicate operation, and it's really hard to find a person who's trained to do those operations. Since there are so many other techniques that are available, and I know I'm going to hear groans, but intermittent catheterization is a lot less risk than doing this surgery in the cauda equina. So most people will say, stick with what you have because it will be a safer procedure in the long run. So those are all kinds of things that you need to work out individually with your healthcare professional. But that's one of the problems with doing nerve surgery is that it is very difficult to find a surgeon that knows how to do it. You might have to travel to a specialty center. You have to stay there a long time during the recovery, and you have to have a lot of physical therapy to help your brain learn to reuse these nerves that used to be one place and now have moved to another place. So it's a lot of work to do these, not only for the person who's doing the surgery, but it's a lot of work for the individual to learn to retrain their brain and their body to work in a different way. But all of these things are still possible. So we have a couple questions that are particular to this, so we'll start with those questions. And so there's a person here who has L1 burst fracture 3.5 years ago, and he's getting around using 2-arm crutches, and he started he started doing PT, and he can walk 1/3 of a mile within a half an hour, and he has some flexion in his hips and knees. Is nerve transfer something that could help me reach the next step in recovery? Well, it might be, because you just might need a little more power to those nerves that are working, because you are doing some ambulation and you do have some function in those areas. Nerve surgery is kind of something that would it's more of an extreme kind of treatment. So probably instead of jumping right to the nerve transfer surgery, you probably want to start with something else that would be maybe more encouraging to getting those nerves and muscles working in your lower part of your body. So, there are some things that are less invasive that will probably help, and maybe you would want to get involved in those, and then kind of at the end, if you're still not at the place where you want to be, you could try some of the nerve transfer surgeries. But I must caution you that these nerve transfer surgeries are very helpful for individual type of functions, like with one joint, or like with a specific function, like in the hands with pinch. You can move a nerve to get pinch. You cannot move enough nerves to make your whole arm work. So same thing with your legs. You could get maybe some more hip flexion. You could maybe get some more function in your knees. So that would be a piece of the puzzle. But it's certainly, this nerve transfer surgery is not a cure type of surgery. It's not going to bring you back to the level you were before your injury. It's kind of isolated to the specific nerve that's moved to the specific place. So if you have some function in your lower extremities, one of the best things that you can do to enhance that function is to use some aquatic therapy. And I know people are like, wait a minute, you were talking about this very fancy surgical nerve transfer thing, and now you're saying go swimming? But actually, aquatic therapy is very helpful to strengthen those muscles that are there. It's not, you don't want to do aerobics training in the water, but you want to use the buoyancy that will help hold up your body and build up your muscle strength as you learn to walk in the pool. So that is an excellent therapy. Another thing that you might want to do is to try some of the advanced therapies. Using the standing frame is going to be an important thing. You might not really need that since you're using the crutches, so you're getting the weight through your long bones. But that's going to be important to make sure you don't get osteoporosis. So putting weight through your long bones is very important. The long bones are in your legs. That's where the bones are really long. That's why we call them long bones. The other thing you might want to do is some functional electrical training to see if those nerves that you have in there could be trained in a different way to carry more of a message. So there's a lot of things that are happening there. You might want to try some partial weight supported walking, where you're suspended in a harness so that only part of your weight is put through your legs to see if you can get that gait pattern established. And then part of that therapy is to allow more and more of your body weight. So as your legs get stronger, it can carry more and more weight. So that might be another possibility for you, as well as doing some of the nerve transfers. But they're probably not going to be the panacea. Nerve transfers are not going to give you the ability to walk. They're going to be able to do things like give you some hip flexion. They might be able to transfer some nerves to give you a little knee flexion. They might be able to find a nerve down closer to your foot to give you ankle flexion. And here again, too, you're looking at long, long distances for these nerves to be moved. So it can be kind of tricky since down in your legs you have to use much longer nerves to go from place to place. Up in your arms and to your hands is much shorter distance. So that's another thing. I should also mention that there's a lot of researchers. There are not a lot of researchers. There are few researchers who are doing a lot of work in the idea of nerve grafting. So getting nerves from donors, from people who have died and perhaps have donated their nerves to a nerve bank, and then transplanting those nerves into living people that could utilize those nerves. The number one problem with that is rejection factor. So if you think about people who have kidney transplant, heart transplants, nerve transplants are very much the same in that you have different tissue matter that's being introduced into your body, and rejection is a huge factor in that. But there's a lot of people that are doing extensive work in that. I must also bring up the idea, which is slightly different, but the Christopher and Dana Reeve Foundation is supporting the big idea, in which is function. It's almost like it is a functional electric device where an electrode, I don't even know what you would call it, but a little device is placed on the spinal cord and then arching over where the injury is, so that you are getting some increased input from your brain. Just this week there was a doctor in France who's put a stimulator in monkeys that have spinal cord injury. He's put the stimulator in their brain, and he's had some success with the monkeys regaining some function. Now, monkeys don't walk like human beings walk. They can walk on twos, but they mostly walk on fours. They use their arms as well. And so the process of walking is different. Also, if you look at the structure of a monkey's body, their torso is much bigger, and their legs are much thinner. Their arms are much bigger than humans' arms. So their bodies are different. But there's all kinds of things that are going on to help try to stimulate walking and increase function in humans. So there are several brain implant studies that are going on, and there's the big idea, which is the preliminary first few that were transplanted using this stimulator have been, in my mind, wildly successful. Now, if you're a person who has a spinal cord injury, these people are not up and walking around, but they have potential that they didn't have before, and so we have to wait and see what therapy is going to do, because they're going to get even more return of function. So, it's all in the early stages, but it's just going marvelously well. So there's another question about the phrenic nerve and transplanting that and grafting that phrenic nerve. And so the phrenic nerve is the main nerve that is inside the body. It's a peripheral nerve that is inside the body that controls breathing. And it's really actually a pretty big nerve. So there's been some experimentation with the phrenic nerve as far as grafting other nerves to the phrenic nerve to help with breathing. The phrenic nerve has been moved to help in different places in the diaphragm to help increase the pull of the diaphragm to cause breathing. And there's been some experimentation of taking a piece of the phrenic nerve, so splitting the nerve, so you still have respiratory ability, but taking that phrenic nerve and putting it someplace else. There's also been for a number of years, and throughout my whole career, I remember one of my first patients was an individual with an extremely high-level spinal cord injury, in so much, in fact, that he was ventilatory dependent, and they put a pacemaker on his phrenic nerve to increase the stimulation to the phrenic nerve. It was controlled by devices on each side of the chest on either side because your phrenic nerve splits off down into two at the diaphragm. And so these were stimulating the phrenic nerve to help with his breathing, and he was, in fact, off the ventilator and breathing. It was an interesting, it was a very interesting thing, because then years later, I saw Christopher Reeve, and he had a phrenic nerve implant put into his body, and so it was internal, not this external thing, and in an attempt to get off, to wean away from the ventilator. So there's all kinds of things being done with respiratory treatment to try to get people off the ventilator, but then also to increase function. So removing the ventilator to increase function of breathing, nerve transfers to improve hand function, and nerve transfers to improve bowel and bladder function, as well as some leg function. We have another person who has had a nerve transfer. Let's see. I'm reading this question here. Is that she hasn't had a nerve transfer, but her understanding is the nerve transfer is done to the peripheral nerve to an area from where you have movement. So how can you be sure that you have damage to the peripheral nerves? Okay, so first of all, let's break this question down. So this is a great question from Nicole, but let's break it down a little bit. So how do you know if you're eligible for a nerve transfer? So what will happen is the first thing that you will have done, the first testing that you'll have done, is our old friend, the EMG and nerve conduction studies. If you have sensation, you don't like them very much. If you don't have sensation, they are not quite so bad, because you don't feel this. They put a little needle in where the muscle is in the muscle conduction studies to see if they can stimulate a muscle contraction. So they want to check the muscle to see if it's working. And then in the nerve conduction study part, they actually will put a needle nearby where the nerve is and send a little electrical signal to make sure that that nerve is working. So number one, they'll make sure that the target muscle where the nerve is going to be transferred to make sure it's capable of a contraction. And the other thing they'll do is they'll test the peripheral nerve to make sure that it's able to carry the message to and from that particular target muscle. So it's kind of a two-part process. Now, if your muscles have become thin or have weakened in any way because you've been injured for a long amount of time, you might need to have some physical therapy to build up that muscle. But muscles are kind of neat in a way that they will build up again. So that's kind of cool. So what they'll do is they'll test to make sure that all your body parts are working in the right way, and then they have to take a nerve from the area above your spinal cord injury where the nerves are still connected, where they're still transmitting the message to the brain, and the message from the brain down through the nerve. So we have to have that connection there. And then they'll take that nerve and either split it or move it to another place. The human body is kind of redundant with nerves. It's kind of like a computer. There's two ways to do anything on a computer, and the nerves are kind of sort of that same way. You can use nerves from one place to another pretty easily. Nerves sometimes are really large, and they don't need to use up all of their nerve fibers to send a message, so sometimes you can split those, or you can take where the nerve has already been split and move it around. So the physician that is working with you to consider nerve transfers can send you for the EMG test, the electromyocardiogram, to make sure that the muscle is working, and the EMG to make sure that the nerve is conducting. This is another problem that's had with these lower extremity nerve transfers, in that you have to take a nerve from above your injury that's still transmitting those messages back and forth to the brain, as opposed to taking a nerve that's in your leg that's not transmitting to the brain. So that's one of the problems with those long connections there. But they are possible. And so here's another question. A person who has a spinal cord injury and also a brachial plexus injury, which is very, very common. And there's no avulsion, so the nerves haven't been ripped away from their connection points. But recovery is very slow, and how long will it take? Well, this is an answer that is kind of interesting, but peripheral nerves grow, reconstruct themselves at a rate of 1 centimeter per month. So if you think about, if you measure, if you have a brachial plexus injury, which is up there right at the kind of the base of your neck, right up there in the shoulder area, right at the top of your shoulder. And if you think about, they're going to reconnect at a rate of about 1 inch per month. So if you measure from the top of the very base of your neck all the way down your arm to the tip of your middle finger, which is the longest one, that is how long it's going to take. So on the base of my neck down to the end of my middle finger is about 36 inches. I have a really long arm, but when you consider all the way up to your neck and all the way down to your fingers, it's pretty far there. So peripheral nerves regenerate about 1 inch per month. So that's going to be 36 months. That's going to be 3 years to recovery. So it's about 1 inch per month is what we say for peripheral nerve regeneration. If you think about peripheral nerves going down into your toes and how long that will be to regenerate, you can see that that's quite a bit longer area of body to cover. So back to the spinal cord injury and the brachial plexus. If you've had a higher level spinal cord injury and you think about your head is pretty big and it's pretty heavy and it's supported by this neck structure, which is really kind of small compared to your torso and compared to your head. So if you're in a traumatic accident and your head is bounced around a little bit, your neck really can't hold it in place and protect it that much. So your head kind of bounces around. If you think about a person that gets rear-ended in a car accident, they might get whiplash because that neck structure is just not strong enough to support the weight of that big old head that you have all your brains up there in that big old head space. So that's why people tend to get brain injuries when they have a traumatic spinal cord injury. But also if you look at right there at the base of your neck, on the top of your shoulder, and in that area just up under your shoulder area, in the front, that's where the brachial plexus is. And that's this whole bundle of nerves that's coming out of the spinal cord. And that brachial plexus is going to branch off into your arms and hands. And that's going to be where all the nerves that go out through your arms are going to travel through that brachial plexus. Now, if you think about a traumatic injury and your head is bobbling around on your neck, if you pull your neck really harshly one way to the other, front or back or to the side, as in a car accident, then you could see how those nerves might get pulled, and sometimes they get pulled away from the spinal cord. And so that's when we're talking about the evulsion, is the pulling of those nerves away from the spinal cord itself. So a lot of trauma going on there. But this person doesn't have that evulsion, so it can take up to 3 years. If you're a man and you have an arm longer than mine, it will take even longer to that. That's just an issue that's going on. Which brings us right into the next question, and we're going to kind of switch topics a little bit now because we have a lot of questions about pain in this particular session, so let's move on to some of those. Neuropathic shoulder pain in a person with complete C5 nerve injury. So what happens in neuropathic pain is it's a pain that is coming from the nervous system. And what happens is when you have any kind of spinal cord injury, messages are still being sent below the spinal cord injury. Messages are still being sent to the brain because that's what the body knows how to do. When it gets to that place where there is a spinal cord injury, then those messages get either they can't go through or they get scrambled, and what happens is people will have referred pain, so maybe the message will kind of skip over to another nerve, so you might have pain in your shoulder is especially a place where referred pain ends up to be, and that is because you have a little bundle of nerves in about the T4 area. So this person has a C5 injury, so if anything from the lower body is trying to shoot up to the message shoot up to the brain, and it gets to that T4 area, there's this little bundle of nerves in there, and so the messages get scrambled, and sometimes that message from someplace else ends up in the shoulder. There's some different places in the body where that tends to happen, but this is neuropathic pain, so it's actually pain from the nerves. And so what people will tend to do with neuropathic pain is they start out in kind of different levels of treatment. So first of all, people will try, your healthcare provider might try with just some general analgesics like some Tylenol or Advil. This is the lowest level. See if they can take the edge off that pain. If that doesn't work, they'll try some higher level pain medications. Now, sometimes people get put on narcotics, but what a narcotic will do will make the pain duller in your pain receptors of your brain, so it doesn't pick up the pain. It doesn't matter where the pain's coming from. Your brain just becomes duller to notice the pain. But as your brain becomes duller and noticing it, people tend to get kind of lethargic and sleepy, so it kind of dulls everything. like to stay away from those narcotics, which are addictive. There are some medications that you can take for pain control that are specific to neuropathic pain, and that's the Neurontin and the Lyrica. There's also some antidepressants that you can take for neuropathic pain, but you take these antidepressants in doses that are significantly lower than treat depression. So instead of taking 100 and 150 milligrams, you take like 10 milligrams. And those sometimes seem to help neuropathic pain. If it's pain because it's a nerve pain, but it's a result of spasticity, so there are medications that you can take for that. So getting to the basis of what is causing the neuropathic pain is important. Now, there are some other treatments that you can use. Sometimes if the pain is neuropathic, but it's a muscle spasm or cramp that's causing the nerve to become spasming, then you can try some Botox treatments. Those help people with migraines, so there's all kinds of different pain treatments that can be taken with that. Sometimes people with lower level injuries will try pumps that they can put pain that will bathe the spinal cord. There are a few people that will put a pump in a higher level, but you have to be careful of respiratory depression. So most people won't put in a pump that high. There are some that have had it. We had a doctor here locally that was doing it with meeting with quite a bit of success. The other thing that you can try, and this is kind of an interesting thing, is that some people go to therapy and they'll use one of those TENS units, one of those nerve stimulators where they put like an electrode on your the body part that's having this pain. And then these little electrical it's kind of almost, I don't want to call it a massage, but there's kind of like a little electrical burst that goes through that really feels just great. I've had that done to me, and it's like, oh, don't stop. But also, some people are trying these nerve stimulators that are being sold over the counter, and they are pricey. They're like $40 and $50, but you see them on TV. That basketball player Shaq is advertising them, and it's for low back pain. And so some people are putting those on and are having some luck with those. You will really want to talk to your physician before you try one of those to make sure that it is safe for you. And so that would be something that you could certainly try. But it usually goes in that kind of order where you start out with medications, and then you move on to some kind of therapy to break up the pain, and then you move on to higher level of interventions as far as getting some kind of something in there to kind of break that pain message from going to the brain. So that's basically the way the treatment patterns go. Now, some people start out with pain medication. They try it for a few days. This is not working, and they're just forget it. This is not the answer for me. This is the bad thing about pain is subjective to everyone. And, you go to the hospital, they ask you to rate your pain on a scale of 1 to 10. Your pain of a 5 might be rated 5 to you, but my pain might be rated as 10 to me. So there's no equivalency between people. Some people have pain and they rate it really, really high. Other people have pain and they're very stoic and they rate it very low. So it's really kind of hard to figure out pain. So what your healthcare professional will start out with pain management medication that they think will help you. And then what will happen is it takes 6 weeks to build that pain that pain medication to a therapeutic level in your body. You can't just take these nerve pain medications, like when you have pain, you have to take them all the time to build up that tolerance to them and get them in your blood system. So sometimes when you start taking them, you might feel a little groggy for about 9 days, but then after that, you become accustomed to it. Then it's about 6 weeks to see if that particular pain medicine works. Now, granted, we know you're in pain this whole time waiting for some kind of resolution, so it's a very frustrating process, but it's the best we have right now. So what will happen is that after a certain number of weeks, the doctor will adjust the pain medication up, or the doctor will adjust the pain medication down depending on how that medication is working for you. They might want to add other pain medication to, do a combination of pain medications. Again, it's a 6-week process until they know if that's working or not. So every time you kind of jiggle that dosage of your pain medication, it's a long time to wait. And we do realize that you're waiting, and you're waiting while you're in pain, which is a huge issue and a huge problem for people. So it's a lot of patience, and it really comes down to trial and error till the right dosage is found for you and the right treatment is found for your particular case. So it's working with somebody very carefully and really getting that that relationship to work together to find out what's going on that will help with your pain control. So I'm going to go ahead and do the next question, and then we'll go back up to the top because I know there's some questions that we skipped over for the nerve transfers. But this is a person who has a broken femur, so they have a broken leg, and the doctor doesn't want to set the bone because they say they won't walk again. Oh, I hear this oh so often. Okay, so surgery is deemed elective and insurance won't cover it. Okay, so here's a couple of issues. Sometimes what happens when the bones break in a person who's been quadriplegic for a number of years is that when you're not putting your weight through the long bones of the body, or when you're not putting weight through your bones, you tend to get osteoporosis. So then the bones, they get those little air holes in the bones. And what happens is even if you're just moving your leg to get into bed, sometimes the bone breaks. Ugh. And it's a problem because if they go in and do the surgery, there's no way they can repair that bone because the bone still has osteoporosis above the break and below the break. And so that can be quite a problem because there's no way to repair the bone. So there's a couple of things that you can do, Beth, to help yourself because, I just hate that when they say because you won't walk again anyway because, all of us who are in spinal cord injury know in our hearts and our brains that you will. And so you want to be sure and get tested, be sure and wear a brace to support that fracture. The other thing that you want to do is to have your bone density tested and to start, if you need to start treatment to increase your bone density. It takes a long, 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 long time for that to happen. So to get your bones up to a place where they can be treated. And then you might be able to have the surgery if you can demonstrate that your bones are strong enough to be able to take the repair. So they will want to put a plate in there. They have to screw the plate into the bone to hold it secure. But if the bones have a lot of osteoporosis, the plate will just fall off the bones. So you've got to have that bone density. So that's what you need to find out. So is it discrimination? Well, it might be. So that is one factor. The other thing is to make sure that your bones are healthy enough to have the surgery. And I'm hoping that is really actually what the problem is. Not that you have the osteoporosis. I'm not hoping for that, but I'm hoping that it's because of a medical problem is the reason why they can't do the surgery, in which case I wish that they would have explained that to you instead of just, I'm sure you feel like you've just been passed over and passed off. And that's an unfortunate way for healthcare. But I think that a lot of people just don't know that much about spinal cord injury. They don't see that many people, and so they have these kind of archaic ideas. So you might even want to get a second opinion. Once you find out, maybe you've already had bone density tests, and you can get the report from your doctor and find out if your bone density is normal, and then get a second opinion and see, because sometimes you might find somebody who's a little more progressive in their therapy. So just some options to think about. Back up to our first questions is there's a question here about what kind of physical therapy should be given to an individual who has a complete spinal cord injury with paraplegia. And so, excuse me just 1 minute. Sorry about that. So what kind of therapy physical therapy should be given? Well, first of all the traditional therapies should start with the basics of doing range of motion, and then move forward to some strengthening, learn to transfer yourself, and progress from there. So it says with paraplegia, so we don't know if that's an upper motor neuron or a lower motor neuron. Those are ways that the nerves of the spinal cord work, with upper motor being more spastic type of an injury, lower motor being more flaccid. So there are different treatments depending on if you have an upper motor injury versus if you have a lower motor injury. So you will want to talk to your healthcare professional, get a rehabilitation medicine specialist physician that can help guide your therapy so that you are given the proper treatment, because depending on the level of your injury and what type of injury it is going to make a difference in your therapy regimen. There's a person who started on Eliquis, and they want to know what type of pain medication is best to take. I will really highly recommend you speak with your healthcare professional, because if you're on Eliquis, you're on that for a particular reason, and so you'll really want to discuss with them your individual case about the particular pain medication that you should be taking, because you don't want to affect your bleeding, and some pain medications can affect your bleeding factors. So be sure and check with your healthcare professional. Next question, does medical marijuana help with spasms? Well, people say it does. I believe them when they say it does. Marijuana mellows out the body, so it does seem to help with spasms. It also goes throughout the whole body. And so I don't know how bad your spasms are, but the marijuana or even medication, anything that you take in through your mouth, will travel throughout your body. So there's a lot of treatments for spasms that are medications that are very helpful. There's a lot of treatments for spasms that are more local treatments. So, for instance, use of Botox, where the muscle's injected into the muscle. The injection is into the muscle that has the spasms, which relaxes the spasm. It's a temporary fix. You have to, if it works, you have to go back and have it redone. But very commonly done in rehabilitation now for muscle spasms, to use the Botox, because it stays pretty much within that muscle. So a lot of people, think of marijuana as just the end-all, be-all, but, we don't really know that much about it. The government has put out a white paper that says that marijuana will reorganize the brain in adolescence. We're not really quite sure what it does to other people of different ages. For some people with some medical conditions, it's been the only thing that's worked for them, and I'm glad that they have that to be able to deal with with their problems that they have. But for spasms, there's a lot of treatments out there that's available to you that is more precise and probably will help you treat your spasms better than the medical marijuana. Now, I know we have some listeners that use medical marijuana and it works for them, and that's fine, but I just want you to know that there are a lot of other treatments that are out there. Let's see. Again, we have another question about the neuropathic pain, so you want to be sure and start with the medications and then work through the process. It's a very long, laborious process, and so just keep working through that. Here's another person whose husband's had a C5 injury. They have pain in the shoulder, and again, that could be a variety of things and ways to deal with that pain. So, again, working through the pain process of treatment. Another thing which kind of shocks people is to do some very gentle range of motion. Sometimes if you're having pain in a body part or if you have spasm in a body part, doing range of motion can stretch and relax the muscles around that, which will help relieve some of the pain. So if the muscle is getting really tight, doing some stretching and some range of motion in that very, very gently and just to tolerance is a very helpful idea, because that will help relax that muscle, and when the muscle's not so tense, the pressure's off the nerve, and so that helps. I know we're over time, but there's just one more question here is if you have any research available for a person with spinal cord injury with one leg amputated. And, that's not that uncommon if you're in some kind of trauma or if you've had a disease that has affected one part of your body differently. So basically, the spinal cord injury treatment is the same if you have one leg or if you have two legs. The only adaptation is for the amputated leg, in which case you can still do standing. You will need to have some adaptations, either prosthesis to be able to hold your body weight in a standing frame, or to be able to do some of the other therapies, but the process is still basically the same with adaptations for the absence of the one leg. But the treatment for spinal cord injury is still going to be the same. So at that, we're at the top of the hour. So this has been a very interesting session today. Lots of interesting questions. I'm sorry we did not get to them all. If you would like to submit them to the blog, I'd be happy to answer your questions there. And with that note, I will say have a happy afternoon.
Yes, I want to thank everybody for joining us. And again, you can leave a question for Nurse Linda on our online paralysis community at christopherreeve.org/nurse. And she does go in every weeknight on Wednesday from 8 to 9 in that online paralysis community, and answers your questions that you leave there. So please feel free to do that. And thanks again for everyone for joining us, and we'll see you hopefully next month. Bye.
Bye-bye.
Thank you. That does conclude today's conference. Thank you for your participation.